And I don't have any polls, but there are a few points in my presentation where I'm going to stop for audience feedback to provide some interaction. So here are my disclosures. I have a number of research grants related to dementia, mainly from um, national and international grant agencies. I also received an honorarium for participating in the CCSMH guidelines and receive an honoraria from Recovery Alberta for a role that I have with the provincial government in our scientific office. Um, and this ECHO, as you know, was supported by the Public Health Agency of Canada, which supported the overall guideline development, which I was one of the co-leads on the BPSD guidelines. So for today, in terms of learning objectives, we're going to understand some of the symptoms associated with agitation and dementia, review some of the factors that can be associated with agitation, and discuss some approaches to managing agitation in dementia. So what is agitation? This isn't a question quite yet for the crowd, but I think agitation can be quite a broad term, and it's helpful to be very specific. Um, we might think of this, maybe this person is just upset, or maybe they're displaying some agitation. They certainly seem like they're angry about something or frustrated. This gentleman here looks like he's uh, having some vocalizations. Hard to know how distressed he is or upset by this, but maybe experiencing some vocal agitation. This lady here, who's holding her cane, seems somewhat angry, might be upset, and all of these may or may not reflect agitation. But I think these kind of situations are ones that we might think of when we're encountering people who might be experiencing agitation. And why does agitation happen in dementia? Well, I like this approach here, and you've probably reviewed this or other ones in previous sessions about why any behavior change happens in dementia. To start with, the neurodegenerative changes in the brain that are associated with dementia place people at increased risk to stressors in their environment, which can then lead to a variety of behavioral and psychological symptoms of dementia. One of which, one type of BPSD, is agitation. And if we think of things that can make people vulnerable to stressors, or the types of stressors that people can have, I like this approach by Helen Kales in the DICE approach, where there may be factors related to the patient, things like their health history or mental health history, health problems, or potential unmet needs, things like pain, sleep problems, fear, or boredom, which might contribute to agitation, caregiver or care partner or healthcare provider factors, including whether people supporting the person with dementia are experiencing depression or stress themselves, their approach to speaking about dementia, knowledge about dementia, sometimes having a mismatch between expectations and what the person with dementia is able to now do independently, which can change over time. And then, of course, there can be things in the environment which can contribute to behaviors like overstimulation or understimulation, safety issues, lack of activity or structure. I always think of how sometimes being in hospital, as one example, can be stressful for everyone, particularly people with dementia, or some inconsistency in routines. So all these factors can contribute to agitation happening. And when coming up with trying to come up with a plan to assessing agitation or any BPSD, again, like this DICE approach, there's others that are similar, like pieces, starting with a clear description of the behaviors. That's the D in DICE. An evaluation of what might be contributing to behavior change, creating a plan that incorporates best practices and the information from the investigations, and evaluating that plan and often having to adjust or modify a plan depending on how well it's worked. In terms of agitation diagnosis and assessment, in our guidelines, we provided some suggestions about potential terminology or criteria that could be used to diagnose agitation, which I'll talk a little bit here. One is of which is the International Psychogeriatric Association for Agitation and Cognitive Disorders. And then there's a number of other tools that can be used to assess dementia, one of which I'll talk about here, called the Cohen-Mansfield Agitation Inventory. So in defining what agitation means in terms of the International Psychogeriatrics criteria, agitation in cognitive disorders requires that there's a presence of a dementia or cognitive impairment, at least one of the following behaviors that's associated with emotional distress, either articulated by the person or observed that the person seems to be in distress. They recommend that it's persistent over at least 2 weeks, that it's not just a temporary change in behaviors, and that it's a change from the individual's usual behaviors. And the types of behaviors that can be included fall into some different categories, like excessive motor activity, verbal aggression, or physical aggression. The behaviors are severe. They cause distress or disability or impairment in the individual's relationships, their functioning, or participation in activities. And it's not due to some other cause, like a medical cause, psychiatric disorder, or the effects of medications or substances. And it's not always sort of easy or evident whether some behavior change may or may not be due to other underlying conditions, but this is a helpful approach to kind of understanding or defining agitation. And we know that agitation in dementia is quite common. This is a review of studies that have looked at agitation across the world. You'll see it's somewhere in the neighborhood of 40 to 50% of people with dementia will experience agitation. There's some variation in different studies, largely due to differences in underlying populations of people with dementia, but agitation is quite common in dementia and one of the more common BPSD. So maybe for the participants here, what types of symptoms do you think can be included in agitation, or might be some of the common symptoms that people might observe in people who have dementia, where the term agitation sometimes is used? What would be some of the specific symptoms that people might see in their practice? Anyone want to share in the group chat? Yelling? Yep, great. Yeah, so I think these are, looking at some of the responses there, I think these are some of the common behaviors we might say that someone might be expressing if they're experiencing agitation. And it encompasses a variety of different behaviors. Uh, Many of you maybe use the Cohen-Mansfield Agitation Inventory, which is one of the assessment tools. And it looks at a variety of behaviors that may be considered agitation. And I think it's kind of helpful when we're communicating and thinking about risks and severity of symptoms to, try to be specific. So certainly there's verbal agitation, like some of the examples people shared, like screaming, yelling, maybe repetitive vocalizations. Physically non-aggressive agitation, people brought up things like, pacing, generally feeling restless, trying to get to a different place. Hoarding was one of the items listed here. And then physically aggressive agitation, where it can be more risky, like hitting or kicking. Spitting was one of the examples also listed here. And what can contribute to agitation? And so we sort of reviewed some of this in your earlier sessions and in the DICE approach. In addition to the dementia, which places people at risk for developing agitation, our guidelines recommend assessment of what we call biological personhood and psychosocial and environmental factors that may contribute to agitation. And again, I like this sort of triad of thinking about things related to the patient, things related to those around them or interacting with the person who has dementia, and then things in the environment that can contribute to agitation and other behaviors. Now, some of the factors, and in an individual, there can be any number of factors that maybe contribute to agitation, but some of the risk factors for agitation amongst people with dementia have been shown that people who have a younger age of onset of dementia tend to have more symptoms of agitation than people who have an older age of onset. Men tend to be more likely to experience agitation than women, although you can certainly, see agitation in both sexes. More advanced dementia tends to be more commonly associated with agitation. So individuals early on in dementia may, about 15% of people with mild dementia may have agitation, whereas closer to half of people with more advanced dementia. And one of the respondents, or a couple, had mentioned resistiveness to care. That also tends to be something that occurs more commonly in people with advanced dementia. In terms of other factors that can contribute to agitation in the person with dementia is the presence of a mood disorder. So sometimes depression can be expressed as irritability or agitation, and certainly people who have depressive symptoms are more likely to also have agitation. And also people with dementia whose caregivers have increased levels of stress also tend to have higher rates of agitation. And some of this is maybe what comes first, the chicken or the egg, or caregiver stress because of the agitation, but also seems that caregiver stress can contribute to the development of agitation as well. People brought up pain and the relationship of agitation in the chat. And just to highlight the role that pain can play in agitation. This is a study of nursing homes that got a pain protocol to treat all people with agitation with analgesia, initially starting with low-dose Tylenol, um, or to continue with usual care. And so the usual care group is in blue, and the people who are in nursing homes that got a pain protocol are shown in red. And what you see is that by addressing pain, it showed a reduction in agitation symptoms. And interestingly, when they look at the type of symptoms of agitation that improved with pain, um, where they saw most of the improvement was actually in verbal agitation. And so verbal agitation can be a sign, it's not always, but verbal agitation can be a sign of pain or a contributor to agitation. And how does agitation impact on people? Well, we know that for people with dementia, of equal severity of dementia or duration of dementia, people who have significant symptoms of agitation are 2 times more likely to die. Their rate of decline or their change in dementia symptoms tends to be 3 times faster. And it's about 1.5 times more likely to be admitted to long-term care compared to people who don't have agitation. Agitation also increases the costs of care from a health system perspective, and we know is associated with poor quality of life and caregiver stress. Now, in terms of management of agitation, the sort of general categories of treatment are outlined in our guidelines. Are psychosocial strategies, sometimes referred to as non-pharmacological, which are recommended to start first for all people with agitation, even if they have severe agitation, and should be also considered even when medications are needed. Pharmacological approaches or medications are usually recommended when people have moderate to severe symptoms. It's recommended to start low and go slow, and to also use, as low of dose and for a shorter duration as needed to help with agitation. So maybe just quickly here from the participants today, what kind of strategies have you used in to help with agitation in your work? Or what are some things that you've found that have been helpful in terms of psychosocial approaches to help with agitation? You could put those in the chat. Great. Snacks, music, yeah, especially addressing unmet needs like hunger, changing the environment, calm, quiet approach. Recreation, great. Going outdoors, I like that one. Cycling without age. We may have crossed paths, Gene. That's great. So I would agree. All of those strategies that have been suggested in the chat could be uh, strategies that could be used to help with agitation. In terms of our guidelines, what we found is something we've called interdisciplinary approaches to care, which involves, having the entire team receive on behavior symptoms of dementia, structured approaches like the DICE approach or others to assessing contributors to BPSD, individual care plans, and incorporation of meaningful activities. In terms of specific interventions that we found could be helpful or where there's good research evidence, and this isn't to say that other things aren't helpful. Sometimes there's just less research evidence for them. but things like animal-assisted therapy, robotic pets, physical exercise, listening to preferred music, and massage or aromatherapy are all interventions that can be helpful. Some general tips for psychosocial interventions. One of the things that the research literature has shown is that, like medications, psychosocial interventions, and similar to psychosocial interventions in people who don't have dementia, they need to be provided regularly, probably a few times per week, and for a long enough period of time for them to be effective. So these are things that need to be provided regularly or made available to the person with dementia for as long as possible. And while there are a number of interventions that have been studied, um, it's sometimes hard to know where do you start or what do you start with. So some practical things I always think of in my work are like, what options do you have available? Some options are available in some settings or not, and some options are easy to implement or make available, but others may be more challenging. To think about options that would be the best fit for the individual's background in terms of activities, to think about the person's strengths and abilities, and where they're at sort of with their dementia. Some interventions rely a lot on language, for example, or which can be challenging for some individuals, and other activities might be a better fit for them. And also what options, sometimes it's a matter of trying some things and see what options people are able to engage with or to participate in. Just moving on, we can next hear from the participants here about what sort of medications do you sometimes see used for agitation? And we'll share some common medications that people maybe see in their work. Ativan, yeah. Citalopram, Celexa, it's also citalopram. Clonazepam, so another benzodiazepine. Seroquel, Nabilone, Nozanan. Great. Yeah, so there's a lot of medications that are sometimes used for agitation. In terms of our guidelines, our recommendations identified some medications that may be helpful, or where we've at least got some research evidence. So citalopram, which is an antidepressant medication, could be considered in moderate dementia. For severe agitation, antipsychotic medications could be considered, like risperidone or aripiprazole. And then some other medications could be considered harm to themselves or others, where you may need to use a short-acting medication. And there, in our guidelines, are also a number of medications that aren't recommended because they're either associated with high rates of side effects, or they've been studied in dementia and shown not to be effective. So a number of medications that are not recommended for the routine treatment of agitation in dementia. And we'll wrap up there. So hopefully some of the key points to take away before we transition to the case is that agitation is common in dementia associated with poor outcomes. The importance of understanding the person with dementia, the people around them, and the environment, and that psychosocial approaches and medications can play a role in managing agitations depending on the circumstance.
All right, thank you, Dr. Seitz.